One of the things that's becoming more important is the so-called neurodegeneration that occurs in multiple sclerosis. So we know that the primary event is probably focal inflammatory lesions, but there's no doubt this disease is associated with progressive loss of axons and neurons. And we know that because the brains of people with multiple sclerosis shrink between 2 to 7 times greater than the age-matched normal population. And that's an issue. So to manage this disease adequately, it's not sufficient just to switch off new inflammatory lesions, but can we give anything to people with MS to stop that cascade of neurodegeneration? And that's why we're moving into a phase of trying to treat this disease with drugs that remyelinate axons, which is neuroprotective in itself, giving drugs that are neuroprotective to the axon to allow them to recover, and trying to switch off what we call the smoldering inflammation, which is usually due to innate activation. This is microglia that drive, we think, some of the late stages of this disease. And so we're now entering a phase where we're going to be hopefully doing add-on therapies to try and target these different processes. Another thing that we can't treat at the moment is so-called premature aging. We know that what protects people from aging is brain reserve, the size of the brain. And we know that as multiple sclerosis reduces the size of the brain, it's going to bring aging phenomena forward. This is one of the reasons why we need to manage this disease holistically, to try and target things that are known to help with aging. This is mainly lifestyle and comorbidity management. So we think some of the drivers of the neurodegeneration need to be targeted differently. So one of them is, do we have any drugs that can switch off microglial activation? And there are some therapies emerging. There's a new class of drugs called BTK inhibitors, bruton tyrosine kinase inhibitors. So it's a kinase that's mainly expressed in B cells, but also in macrophages and microglia. And we've got some CNS penetrant ones that are in phase 2 and one going into phase 3. And hopefully these will not only target the B cell component of the inflammatory cascade, but switch off the microglial, and we'll see what happens to the neurodegeneration in that. Another driver is we have these things called slowly expanding MS lesions. They are a very characteristic lesion, is that they've got a rim of microglia around them that are activated. And we see them on MRI scan with susceptibility imaging. They've got an iron rim, and these lesions just get slowly bigger over time. And they're pretty destructive. We know they're destructive because if they occur in a specific site, like the top of the spinal cord, people do really badly. They get really bad quadriparesis from it. And so we know that these lesions don't respond very well to our standard anti-inflammatory therapy. So we're probably going to need another form of treatment for these lesions. And another part of the immune cascade that we don't target with our current therapies are the what we call the intrathecal, inside the brain and spinal cord, B cell response and plasma cell response. We think some of those antibodies that we find in the spinal fluid are pathogenic, and they may be driving some of these lesions. So, is there a way we can target the B cells and the plasma cells within the brain and spinal cord? So just to give you an example, we're starting a safety study of a myeloma drug that targets plasma cells, a CNS penetrant one with a proteasome inhibitor, to see if we can try and scrub the brain clean of the plasma cell response, which produces these immunoglobulins. So we're beginning to see people evolving in a different therapeutic strategy to treat multiple sclerosis. I think it's also important to stress, though, that this degenerative process that happens in MS doesn't just begin later on in the disease, it's present from the beginning. And we know this, though, because when we measure brain volume loss using MRI metrics, it's there from the very beginning of the disease, even in the asymptomatic phase of the disease. In people who are picked up of having MS on the MRI scans when they go to a neurologist or a healthcare professional for another reason. It could be headaches. They get a scan and they identify MS lesions on their scan, and they have MS because when you follow these patients up, they often develop MS. And already these people have got brain volume loss and they've got cognitive problems, which tells us that the pathology of this disease is degenerative from the beginning. And I think that's another reason for trying to treat this disease early rather than late, because if you want to prevent the cascade, you've got to treat this disease as early as possible. And even when you interrogate these patients that have got asymptomatic MS, you send them off to the psychologist for detailed neuropsychological testing. A significant number of them have got cognitive impairment. So there are consequences to the neurodegenerative phase of the disease.